Good evening. On behalf of Sutter Health, welcome to tonight's session on knee and hip pain. If your joints ache, you've come to the right place. The orthopedics program at Novato Community Hospital and California Pacific Medical Center are some of Northern California's best. And tonight, we're going to learn about joint pain treatment options from Dr. Peter Callander. He'll share a great presentation and then answer your questions live at the very end. We're really grateful for this webinar technology so that we can be with you here tonight. So just a matter of quick business on how an online webinar works. Now, we can't see or hear you, so when you have a question for the doctor, anytime during the presentation, scroll your mouse or pointer over the screen and you'll see a little Q&A button at the bottom. Just click Ask a Question and type it in. Dr. Callander will answer your questions at the very end. And once the webinar is over, a survey referral form will pop up on your computer. And on the form, you can ask more specific questions to your medical needs, give us some feedback about tonight's webinar, and you can schedule a consultation with Dr. Callander if you're interested. So enough of the formalities, let's get on with the presentation. Tonight, we're really lucky to have with us Dr. Peter Callander. He's an orthopedic consultant to the San Francisco Ballet and other sports teams. He's recognized as one of the top orthopedists in the country. He specializes in hip and knee replacements, orthopedic surgery, and surgical arthritis, with an emphasis on minimally invasive techniques. He graduated from Stanford University, received his medical degree from St. Louis University, and completed his orthopedic surgery residency at UC Davis. Dr. Callander then completed fellowship training in knee and hip replacement surgery at Cornell University in New York City. He has performed thousands of hip and knee replacements, countless complex reconstructive surgeries, minimally invasive procedures, and treated many others with non-surgical options. Most importantly, though, his patients have some of the best exceptional outcomes and they live without pain. And despite a very busy schedule, we're glad he can make it tonight. So welcome, Dr. Peter Callander.
Thank you, Sean. Appreciate the introduction. You know, when you give that introduction, it kind of reminds me with all the education. I think I made it to the 28th grade. So we've survived. But I'm thrilled that all of you are doing well, and welcome this evening, everyone, to our Novato Community Hospital seminar. I'm going to talk to all of you this evening a little bit about how we deal with joint pain, and this topic is going to incorporate a little bit about the conservative aspect, but more importantly, we're going to talk about the latest and greatest in technology when it comes to hip and knee replacements. So what I'd like to do, I'm going to mix this up a little bit. Let me first share my screen. And what I want to show you is, well, who we are here. So I am one of the many orthopedists that work at Novato Community Hospital, but my group is a private practice called California Pacific Orthopedics, and we're based in San Francisco and Marin County. And we're made up of about 12 physicians. And all of us came together. Well, the group came together in 1977. Just a little historical background. We're multi-specialty. And in that multi-specialty, we include sports, spine, foot, ankle, hand, shoulder, and hip and knee. And along with that, what's very unique about our group is that we have 12 partners and everybody's fellowship trained. So going back to what Sean was saying of all our training, not only do we go through residency and medical school and residency, but then everyone is in a special training, and it's a fellowship training area, be it in foot, ankle, or hip and knee. And so that's what we see at Novato as well. All our orthopedists up there that treat our patients are fellowship trained, which makes it a very unique situation. In our facility, we have X-ray and MRI so that when you do come see us, you will be it'll be part of your visit. You don't have to go somewhere else. Everything is here, all your ancillary services. We are part of UCSF. I actually do a lot of training of the residents, and UC has asked us to be their satellite. And so we work with UC a lot. And so all of the information from your medical background will rotate through UC. However, we use the Sutter facility for our surgery. So as an independent contractor, I work at Novato Community Hospital because it's a great place to work and it's a fantastic facility. And I'm going to touch on that a little bit later. Other places that I work are in Marin and the Presidio Surgery Center. Our offices are in San Francisco and San Rafael. This is our team, and it's made up of 12 physicians and 12 surgeons along with our physician assistants. And what we have in our group is spine, shoulder, elbow, hand, sports medicine, hip, knee replacement. There I am under hip, knee. And then my partner, Dr. Maley, also does it, Dr. Cox and Dr. Belzer. We have sports medicine with Dr. Chan and Dr. Green and so forth. So these are names you may recognize. But one of the exciting things about our group is that we cover some pretty fun groups that like to play sports. One is the Warriors and the A's. We're the team doctor for them. And then my area of that I love doing is taking care of the San Francisco Ballet, which makes it a lot of fun because I'm there on actually my office. I have one little room right underneath the stage, so it makes it lots of fun. I'm throwing this picture in because I don't know if any of you have been watching the Olympics, but this is my patient, Eileen Gu, and she is from the US, but she's actually representing China for the freestyle skiing event, which is the half pipe, the slope style, and the big air. And just last night, she won gold. So I'm absolutely thrilled that she was able to do that. So keep an eye out for her. She's going to do some more jumping for us the next couple of days, and she might even walk away with 3 golds. So very exciting, and been texting her back and forth, making sure her knees feel good. So she's A-okay. So let's talk about what we're going to talk about today, and that's our hips and knees and beating old age with new joints. And the way we do that is with the latest technologies and hip and knee replacements. And as I said earlier, we're going to talk a little bit about the conservative aspect, but then bump into mainly what's the latest and greatest in technology and surgical treatment. So I love using the analogy of the car because that's pretty much what our joints are. We're walking on our knees and hips, and they're like tires. And if our tires wear out and the tires go down, what happens? You're riding on the rims. And when you're riding on the rims, it hurts. And so I love this cartoon. It makes a creaking, popping sound every time I get in and out. And the mechanic goes, "That's your knees, sir." And many of us experience that. And what are the symptoms? Well, you end up having warm joints when you're sore, and arthritic joints can swell. You'll maybe notice you have decreased mobility, you may get stiff, especially in the morning, and your decreased level of activity. You can't keep up with your friends, do the things you want to do, and your overall lifestyle is impaired, and you might even see a little joint deformity like we see here. Here's some knees where the top picture shows someone who looks like he's been riding a horse. We call that a varus deformity. And here your knock knee or a valgus deformity, and this is what the x-rays look like down below. And so there are various treatments that we go through for patients before they reach the surgery level. One is just anti-inflammatories. That's always very good, but you don't want to be on those too long because they can eat away your stomach lining. So that's something to follow closely with your primary care physician. Also, physical therapy is a key role. They keep your joints moving, keep you upright, and help to control pain as well by not getting too stiff. Steroid injections and other type of injections such as viscosupplementation, PRP, even stem cell. Those are all options for joints. Let me just tell you up front, I think the PRP and the stem cell are still in their infancy. I tell patients we are literally in the garage. We have not come out yet. We're still trying to figure it out on rats and mice, and we cannot make cartilage. You can read any magazine in the airport or on the airline that says, "Hey, take this and you'll get new cartilage." That does not happen. It does not happen. You can try PRP, which is platelet-rich plasma. That may give you a little relief because it's an inflammatory response, but it does not make cartilage. The bottom line is that when you wear down your joint, you change the overall structure, and you end up having wear and tear in the joint. That's osteoarthritis, and it leads to bone on bone and pain. And so steroids help because cortisone is an anti-inflammatory. You can inject that, but it's again short-lived. There are other options such as viscosupplementation. You may have heard of Hyalgan, glucosamine injections. Those have a 60-40 success rate as well. So a whole nother topic, whole nother lecture about injections, but I just wanted to touch the tip of the iceberg on that for you. And that's where we can go with injections. Another area that helps, and very basic, but look at your weight, get your weight down. You get your weight down, you have less weight across the joints, and then the joints start feeling better. All these fail, the next step is surgery. And I want to talk to you a little bit about that. So overall, the patient experience, what is that like? Well, it's changed quite a bit. I love this cartoon. It can say I'm entirely pleased with my hip replacement. But the hip replacement has changed. From 1975 to 2022, things have really, really changed. And what's new? Well, your hospital stay is much shorter. I can tell you today, I just did 4 hip replacements starting at 7 this morning. Every single patient went home. Not a single one stayed. Now, these are patients that are on the younger side, but if they need to stay, they can stay overnight. But we're seeing patients do same day or 23-hour. Multimodal pain management is one of the reasons that you can go home sooner, because we do blocks. We also do what we call a spinal, where we just put your legs to sleep. We don't do a general anesthesia. Because when you have a general anesthesia, you end up waking up feeling nauseous. And if you're nauseous, you're not going to move much. You're going to feel ill. So if we can get rid of the nausea and have you more alert after surgery, then you are ready to go and get moving and out the door. So this leads to a quicker recovery. One of the things that helps with that is we have smaller incisions, quicker surgeries. Quicker surgeries means less blood loss. Less blood loss means less lightheadedness. All these things help. And so at Novato, we really take a concierge approach. So if you're my patient and you decide, okay, Dr. Callander, I want to have my hip replaced. Okay, so we talk about it, we set a date, and then Novato steps in and they're going to say, okay, Mrs. Smith, you have decided to have your hip done. We need to talk to you on the phone. We need to make sure you've seen your primary care. We make sure that you've done all your labs. We want to know what your home situation's like, who's going to take care of you. All these things are, cross-check, double check, so that your overall stay at Novato is going to be a positive one. We want you to feel like you're going to camp and you've got your checkoff list and everything is ready to go. And so that's really our concierge approach. And I might also add is that everybody knows you when you arrive, from me to the nurse, to the physical therapist, the occupational therapist, the anesthesiologist, everyone. So you are part of a team, and that team approach is what we call a win-win. Okay, so what's new? In technology, we have new instrumentation, new state-of-the-art operating tables. The designs, the materials, and the techniques of the surgery have changed immensely to make everything move much, much quicker and getting you out the door. We also have 3D printing, and I'm going to show you that. And I use that a lot with knee replacements, and we use robotics. So very exciting stuff. All right, so let's start with hips. I recommend a hip hop replacement. And let's hip hop over to this picture on the left. You'll see that the joint shows to be, you see my cursor, it's nice and round, and you have lots of space in there, and that space in there means that you've got a lot of cartilage. But if you look to the right of your screen, you'll see that the space is gone, and that's what we call bone on bone. The most common kind or type of arthritis is osteoarthritis, which is wear and tear, loss of bone, where loss of cartilage leading to bone on bone. Now, there are other types of arthritis. There's rheumatoid arthritis, which is an inflammatory. There's post-traumatic arthritis, which occurs after a trauma. Maybe you fell off the horse when you were a child and now you have arthritis in your joint. You can have septic arthritis, which is an infection that led to an arthritis. So there's many types, but the most common one is osteoarthritis, and that's what we're going to talk about. And the way we replace the hip is by taking the ball off that's worn down, and we use literally a saw. It's an oscillating saw to take that out, and that's why I love this, because it's a great job, I get to play with toys. And so when we do that, I'm a carpenter and I go from there to putting the stem in. And then the stem is making the socket and it's a bone. It's a new hip socket with a ball and socket. And now there are different ways to do hip replacements. You can either go through the front, which we call anterior, or you can go through the back, which is posterior. The posterior approach is a traditional approach that many surgeons do, and many surgeons do well. The anterior approach is more state of the art because by going through the front, we end up doing a replacement where we don't cut muscles, we separate the muscles. And by doing that, we have less pain and a quicker recovery. If you go through the back, you have to cut some muscles, makes it more difficult to get up. And you also have more hip precautions with the posterior approach, meaning you can't bend your hip more than 90 degrees for 3 weeks. You can't do this rotation or that rotation. With an anterior approach, there's fewer postoperative precautions, which allows you to get up and recover more quickly as well. And with the anterior approach, we can use X-ray, which gives us more accuracy with the procedure. So if you look at the left of your screen, you'll see the posterior and anterior approach incision sites, and those are the different areas where we come into the hip. And on the right, you'll see it's a very small incision with all these big instruments that we use. And the reason I go to college and med school and fellowship and everything is to learn where all these little critters are. And these are nerves and arteries. So you definitely, I show this because you want a surgeon that's going to replace your hip to be a fellowship trained surgeon. You don't want someone who's a general orthopedics like, oh, he kind of does a hip and knee replacement here and there. You want someone who does a lot of them because it's like anything. You want whoever does it a lot is good at it. And you got to know where these nerves and arteries are, because if you don't, you can get into some trouble. So I'm going to show you a video. This is a skeleton showing us the approach, and these are markers that we use to identify where we make our incision. So we're going to go through the anterior approach of the hip joint. And so I'm going to put some muscle in there to show you where the muscles lay. And then you'll see that I use retractors to just pull the muscles apart. Okay. And these muscles allow for clear exposure of the joint. And then that area is called the capsule. So we open the capsule, and then I bring in a saw after I line it up with an X-ray to show exactly where I make my cut. And there's the X-ray showing me that I should make the cut just right here, because you want to make sure when you make the cut that you don't make it too short or too long, because what do we end up with? One leg may be too short or too long, and that would be bad, because if you have one leg too long, then you walk in a circle and that doesn't look too good. So here we take the head out, and the head comes out and it gives us clear exposure of the joint. So now we're looking into the joint, or the acetabulum, and we take this instrument, which is called a reamer, and we're going to ream out any leftover cartilage down the bone, because we're going to put in a new socket. And the new socket is this right here. And it's what we call a tapered fit, where it's a little bigger than the socket. So when we punch it in like this, you'll see it will go bang, bang, and just tap, tap, tap. And then the bone is going to grow into that socket. We don't use cement anymore. In the old days, they used to use cement, but as you know, with cement, what happens? It eventually loosens. We don't want that, because that means we got to revise it and come back and do it all over again. This is a special table that I use that allows me to have clear exposure to the hip joint. These are tables that they never had 10 years ago. And so it allows me to rotate now the femur. So we're going to look down the canal. So I'm going to lower that leg like you saw in that picture. And then the femur rotates up like that. And now I see the marrow, and the marrow is where we're going to put the stem in. So we take these broaches, which are different sizes, and we go 1, 2, 3, and they use these. This is actually called a cookie cutter, and we cut it in alignment of the cortex around the bone marrow. And then inside that bone marrow is where the stem is going to go. So we're going to broach different sizes according to your size. Now, patients say, oh, Dr. Callander, what am I going to do if you don't have the right size and I'm little? I was like, don't worry, because I always tell them it's like going to the Nordstrom shoe department. We got every single shoe size. I got every size of hip. And so as I do this, I will fit your size. You're either 3, 4, 5, 6, or 7. If you're a 6, I just take the 6 out and I'm going to put it in. So let's say this patient's a 6. I fix the size 6. And then we take this little, we call it calcar reamer, and we trim down the bone, make it nice and smooth. And then we're going to cap it with the new head. And so once we put this new neck and head on, we can measure those different lengths so that we make sure that your legs are the same length and stable. If you're too short, then the hip's going to pop out. We don't want that. So I'm using x-rays, you can see here, that shows me where the hip should be. And then I can move your hip on the table and make sure that it stays in the right place and it doesn't pop out. Because one thing you don't want is a dislocation. And at the same time, at the very bottom, I can see that the legs are the same length down here, right? So with the x-ray and that approach and seeing the stability, making sure that the hips are the same length and the same offset, then you have a nice balanced hip. And that's the benefit of an anterior hip replacement. Okay, so we'll go to the next one. And this is what the OR looks like. We wear these big spacesuits. Why we wear that is because by having a spacesuit, it protects you and me from infection. We don't want any infection. So all our OR rooms at the Novato Community Hospital are specific for joints. And so we want a very clean room. And this is a patient who is in her private room at Novato, very nice, actually has a little deck and you can look out over the trees. And she just got up on her own and sat right back down after she walked across the room there and back with her walker. And she is in her 80s and she is 3 hours, I repeat, 3 hours out from surgery. And why I show this is that I want people to know that, look, you come and get your hip replaced. She doesn't look too stressed out. She's actually a very happy camper because she has no pain, because we use this multimodal effect where when we're done, you have very little pain, you're all numbed up, but enough motor function that you can get up and get moving. And so she, being in her 80s, will stay overnight and go home first thing in the morning after she does some PT sessions. So very, very exciting. Go to the next picture. Now, this is a different kind of surgery called hip resurfacing. It's an alternative to the traditional hip replacement. And I use this for my young active males. So ladies, this is not an option for you, unfortunately, because as you age, your bone gets a little softer than the men. And because of that, this type of design of hip is for young males that can have their hip resurfaced. Instead of taking the head off, we're going to ream down the ball and cap it like a tooth. And I'll show you a picture. But the main thing about this is for active 30, I have patients in their 20s, 30s, 40s, 50s who need hip replacements because they have the osteoarthritis gene. And so they get it and they are miserable. And by giving them this surgery allows them to bridge with a hip replacement called a hip resurfacing. And if that fails, they convert to a standard hip replacement, which allows it to last a lifetime. So you preserve the bone, you increase your stability because it's a larger head, and again, higher activity males. I learned the design and the technique in Birmingham, England with this gentleman, Derek McMinn, who helped design the hip resurfacing implant. So the two of us worked together, and so I was handpicked by the company to fly out. And so I was one of the first hip resurfacing surgeons in the United States when it was FDA approved in 2006. So here is what a hip replacement looks like. As I show you, put a socket in, a liner, then we put the stem inside the canal, put the ball on, and there you have your traditional hip. Now, back up and let's do this again. Now what we're going to do is we're going to put a socket in, just like we did with this traditional hip, but instead of taking the head off, we're reaming it down and we're going to cap it. And then we put that together, and that's what we call the hip surfacing. So that's the difference between the traditional hip and the Birmingham hip. You have more bone stock, and that can last so that when it wears out in 20, 30 years, you just take the head off that bone and you convert to a traditional hip. It's a lot easier doing that than to start with a traditional hip and revise that. And you can have a lot more complications with that. Here's a patient, and he's 28. And he's 3 months out from a hip resurfacing. You can see he gets right up. He's a young, active male, but a perfect opportunity for him to have a hip resurfacing. Here's a 40-year-old who's doing this kite surfing. And again, 3 months out. Really amazing. The next patient I'm going to show you is in his early 60s, and he's an avid skier and actually gives us a little scenario about how he felt with the surgery.
I feel like I can ski like I'm 30 again. So skiing has become just a real joy. My overall health is improved. My movement's improved. I have absolutely no pain. If you'd asked me if I would do it again, in a heartbeat. I just wouldn't have waited so long.
And that's, what people always say. And so for those of you in the audience who are going, oh gosh, should I do this or not? If you're in a situation where you have pain and you're limited in your activity and can't do the things you want to do, don't put this off. If you failed all conservative measures, hip replacement is the way to go. Okay, so let's talk about knees. Same concept, a joint that's worn out, you got bone on bone, it's arthritic. And when it comes to knees, I actually do have a couple tricks up my sleeve. And we have some knees that are pretty tricky now. The things we can do with these knees is pretty amazing. One thing that's very amazing is this picture I want to share with you. This patient just came into my office a month ago and brought me this picture. And I had done both of her knees last year, separated months apart. And then she decides to go climb Mount Kilimanjaro. And so, as you know, in Africa, this is the highest point in Africa. And so what I love about this picture is she went all the way, climbed all the way up there, and the sign she brought with her. So I thought it was absolutely adorable that she brought a sign that said, "Thank you, Dr. Callander," unwrapped it from her backpack, and then stood under this big Mount Kilimanjaro marking. So pretty fun. And what's so great is that when you do get your knee replaced or your hip, you can get back to what you want to do. Life is short, so let's make the most of it. So knee replacements. Knee replacements have come a long way again. Short surgical time. It's not a long surgery. I usually do my surgery in less than an hour. And when you have it less than an hour, what happens? You have less blood loss. You don't have the risk of clots. Now I use a lot of technical advancements and the use of computers and robots that we have better alignment. Why is alignment so important? Well, think of your car tire. When you go take your car in, you get a new set of tires. What else do? They give you an alignment, because if they're not aligned, you're going to wear one side or the other. You're going to come back sooner and have to replace the tire. If you have your knee well aligned from the start, it's going to last longer. And people ask me, how long do they last? 25 to 30 years is really the going rate right now on knees. So that's pretty good. The implant survival, as I said, is excellent. And a lot of that is because of the design of the implant and the materials that we use. The materials are just light years ahead of where we used to be from the standpoint of low wear. So the big pariah of an orthopedic surgeon is wear. And I don't want to put something in that's not going to last, because if it doesn't last, we got to come back and do it again. And you don't either. You want something that is going to be done, one and done. So Dr. Callander, let's do this knee replacement, and I don't want to see you again. So that's my goal as well. And it's a minimally invasive approach. And again, we use medications that allow you to recover quickly and get up and going with minimal pain. So let me show you, this is a video showing what the knee joint looks like. And our goal is to eliminate the pain, but reconstitute what the joint looks like with new design materials of the implant. So looking at this, I tell people that patients that the knee joint is kind of like a hinge joint. It does rotate a little bit. So it's not just back and forth, but it also goes back and forth, a little rotation. And when it does that, you have to have an implant that can pivot. If it pivots and stays aligned, then you have a win-win situation. And so what happens is that we're going to resurface the ends of the bone, because if the ends of the bone right now have lost cartilage, and if you have no cartilage, you have pain, and then you have fatigue. So here's a computer model showing the back and forth and rotation of the joint. So we're going to resurface the ends of the bone by clearing off the arthritis and capping it like a tooth, kind of like the hip resurfacing. And then we slide this little plastic in between. Now, the materials that we use have changed. We use a zirconium that's oxidized called oxinium, and it's black. And that black is really a ceramic that's as hard as steel. So it's as smooth as ceramic, but as hard as steel. So if you took ceramic and dropped it, it would break in 1,000 pieces. Well, you don't want that in your knee. What you want is something as strong as steel, but as smooth as ceramic, and that's the zirconium. and the zirconium that's oxidized called oxinium. And again, a big change when it comes to survival rate. The liner itself is what we call a high cross link liner. It's a plastic that doesn't wear. So the fluid that you make in your joint sinks in between between the knee joint implants to make it move smoothly. So what do we use? We use this thing called patient-specific instrumentation. And what I use here is if you decide, okay, Dr. Callander, we've done everything, we've failed all conservative measures, it's time to get a knee replacement. What I'm going to do is have you get a long leg x-ray and an MRI. And we take those two pieces of information and I put it in the computer and we design these cutting blocks. And these cutting blocks are customized to your knee and to your knee only. Through the MRI and the long leg x-ray, we make these cutting blocks. And then they sit on the ends of your knee and they're going to make specific cuts. So the computer knows exactly the length of the bone, the rotation, and it sits there custom to your bone. So this is a femur bone, someone's femur, and this custom cutting block will sit on there. And I fix it in place with these pins, and then I come in with a saw and I make a cut. And so the computer has already decided what type of cut you need to have, because by having the appropriate cut, then what happens is you'll be able to put the implant on with just the right amount of thickness, rotation, flexion, extension, all these things. It's like putting up a cabinet. You want to make sure it's completely even. You're not going to put something on crooked. You want it all straight. And so that's where the computers come in. And so by using these cutting blocks, I just go through this little slice here, that little space in the saw, and it guides me. So it's robotics, but you're showing up with your homework done. So I don't use the robotics right here. I'm using these cutting blocks. Okay, so hopefully that's clear. Here's a patient.
The surgery itself was as easy as it could be. The knee is fine. It doesn't hurt at all when I play golf. I'm just sorry that the knee couldn't fix my golf game because I'm getting too old to play effectively anymore.
So I love that picture. She just, right in, hole in one. Very good. And she's in her 80s and a happy camper with her new knee. Again, we use those special cutting blocks so she's well aligned. And it also helps because you get your range of motion back. And that's key. You worry about getting a stiff knee, and you don't want a stiff knee because then you got other problems. All right. Then there's the knee that only part of it is worn out. We call that a partial knee OA, and we want to do a partial knee replacement. Again, quick recovery, less invasive. We maintain natural knee function, and we're going to use robotics in this one. Well, not always, but you can see in this x-ray where it's a smaller incision. Here's the area on one side where you're bone on bone. So we don't need to replace the whole knee. We're just going to replace the area that is. So
extremely dangerous to Earth people.
Some of you who are in certain decades of life may remember Lost in Space. So this was that robot, I don't know, M9 or whoever his name was. Well, robots don't look like that anymore. They now look like this in the OR. And it's a screen. And what we do is we measure on your leg exactly where the knee is in space. And then we can align the thickness of the joint with touching the bone with the computer. And then we can pre-program exactly where the cuts are. And then we take this cordless kind of computer generated guide that's a drill. And what you do, if you look at the very end, it has a little drill bit and you literally hold it onto the bone and it will burr into the bone the appropriate depth. If you go too deep, it stops. So the robot tells you exactly where your cuts need to be and where we put our little insert holes where the implant is going to fix. And so then the implant comes in and we lie it in on the tibia, which is on the bottom, and on the femur at the top. And then that's a fix with cement. And there you go. So just wanted to show you that's how we use robotics as well in the operating room. So again, lots of fun technology, and all this is being done at Novato Community Hospital. Yes, it's Novato Community Hospital, but it's really Novato Community Hospital that's become the new, UC or Johns Hopkins expertise. I mean, you've got guys and gals who are surgeons there that are top of their game, fellowship trained, and are doing the latest and greatest in technology. So very, very exciting. Here is some tables. This is 2017-19 of follow-up of our patients and their satisfaction. And we now have 2021, 22. I don't have that slide, but we're up to 97 and 85. And when I show this is satisfaction and 1 year out. We're now in the 90s in knees and high 90s in hips. People may have told you, okay, I had my hip replaced. Oh, it was a cinch. I got up and everything was great. And then those that had their knee done, oh boy, that hurt a little bit. So I'm going to be very candid. Knees hurt more than hips. And if you take the analogy of your finger, if you jam your finger, it gets swollen. So it only can move up and down. And when it's swollen, that hurts. That's kind of like the knee joint. But with your thumb, if you jam your thumb, you can move it this way, this way, this way, this way. And that's like a hip joint. So you have more space in the hip than in the thumb than the finger. Same idea with the hip and the knee. So that's why we see that the hip replacement procedure is less painful. Now, understand that you're not going to be in excruciating pain. We have blocks, we have medication, we have lots of little tricks of the trade to make this experience tolerable and not a nightmare. You're going to do great. Patients love it. And once you're done, you're going to be able to get your life back and be much more mobile. So the next slide I want to show you is a sweet video of a patient of mine who sent this to me, and I just love it. So I want to share it with you. So she sent this to me in the mail, new hip, and her knee was taken care of. But the bottom line is you get to go back and do what she liked to do. And she's a big scuba diver and was thrilled. So on that note, thank you very much. It's a pleasure to have the opportunity to speak with you this evening. Thank you for taking the time on a Wednesday night. And I'm going to pass it back to Sean. And Sean, I believe we may have some questions. I'm happy to answer questions along the way.
We do. And Dr. Callander is going to stop sharing his screen so you could see him. And then we're going to entertain the questions. And we just want to remind people that even while Dr. Callander is answering the questions, you may have some that pop up. And if you do, you can still ask questions or type them in anytime while he's answering them. Just look for that little Q&A button at the bottom and click ask a question and type it in. And he's live and he's here and he can answer the question. So believe it. All right. So we actually have a couple of questions. So I'm just going to bunch them together regarding hyaluronic acid. About 4 questions about that. So the questions are all, what are your feelings about hyaluronic acid?
Okay. Well, hyaluronic acid comes in different flavors. You've got Euflexa, Synvisc, Orthovisc. And as I said a little bit earlier, it's really it's like feeding cartilage. It's a glucosamine chondroitin sulfate. We learned about glucosamine chondroitin sulfate really with horse racing. We would give it to the horses and they would do a lot better. And everyone goes, hey, that horse is going fast. I want to try it. So it, again, doesn't make cartilage, but what it does is I think of it as feeding cartilage. And it's articular cartilage. It's made up of a protein and keratin sulfate, and these different proteins form a conglomerate that can feed the cartilage. And some people find that they get a benefit from it. So I tell it's about 60-40. There's a study out of Canada that gave that kind of positive result, but you have to understand that it's not for everyone. And if you're pure bone on bone, this thing is not going to do anything for you. But if you're on the early stage of cartilage wear, then you may consider it. And I use it for patients who are, well, Dr. Callander, I'm thinking about it. It hurts, but really don't want to do surgery. This is a perfect option. But if you're pure bone on bone and you're in a lot of pain, it's not going to work. So that's the bottom line.
Great. Thank you very much. I see that a couple of people raised their hand, and for this session, that's not going to do anything because we can't really call on you. So just go to the Q&A button at the very bottom and click ask a question and type it in, and Dr. Callander will answer it. Okay. The next question is, can your pain and surgical treatment not include opioids?
No, good question. A lot of our patients, when we do the surgery, first off, we do a spinal, okay? And the spinal puts your legs to sleep. And then what we do is we'll give you propofol, which is that white milky fluid that many of you may have had when you have like a colonoscopy. So put you in the twilight zone and you take a little snooze. And so you don't see or hear anything. After surgery, at the end, we put a lot of marking pain medication in the joint. If it's a knee, the anesthesiologist will also do dual block. The reason I talk about all this is because by having that, you don't need to have the strong, Dilaudid and oxycodone and OxyContin and all those other drugs to get through. However, oxycodone, we don't use OxyContin anymore, but oxycodone is a tolerable drug, or a Vicodin, and you may have some pain for the first 5-10 days, and you can take that. You're not going to get addicted. You'll be fine. But you can also mix back and forth with like Tylenol and the oxycodone, and then wean off of it and eventually go back into an anti-inflammatory. I do have patients that have very little pain and they just go home with Tylenol. So everybody's a little different, and there's not a single answer for this, because some people have high tolerance and low tolerance, or someone may have come in having been on a lot of big drugs, so their tolerance is going to be low and they're going to need a narcotic. But overall, most of my patients may need a oxycodone for a few weeks and then you're done.
Great. Thank you very much. I'm going to combine a couple of questions here about PRP. One question is, and I think you could probably answer these all at the same time. One is, what diagnoses are treated with PRP? How long does PRP treatment last? What is the success rate? And if it's still in its infancy, do you prescribe this, and under what circumstances?
So PRP, or platelet-rich plasma, is where you take your platelets from your blood, you spin it down, and then we put it into, let's say, your elbow, or you have where I see it's very successful is with tendons. Some people that have like lateral epicondylitis or tendonitis, you inject it into the elbow and it stirs an inflammatory response and helps with the healing phase. When it comes to joints and you have osteoarthritis, you can have it done. And people, get a positive response, but it's more, you're getting a response because it's an inflammatory response. And so your knee or your hip feels better because you have all these cells coming in and trying to fix the situation, but it doesn't fix it from the standpoint of making cartilage. Do I prescribe PRP? I would use it more for patients with tendonitis. Some people use it for Achilles tendonitis, things like that. But I'm not a big fan for joints and arthritis. I just haven't seen a big success. I can tell you I've had many, many patients who show up at my doorstep and have had PRP or stem cell, and they spent thousands of dollars and they're still at square one, wishing they never had done it. So there are some that come and say, oh, Dr. Callander, I had a few months off and it helped. Like, great, I'm glad it helped, but know that it's not going to make cartilage.
Great. Thank you. The next question is, have you done a lot of revision hip replacement from metal on metal recalled hips, and how successful is the surgery?
So as some of you may know, there was a recall, maybe it's about 7 to 10 years ago now, with Johnson & Johnson. It was a DePuy implant that was metal on metal. And the reason why it failed is that they heat treated the metal twice. And so the hemisphere of the cup was shallow. So when you had the ball on the cup, it would edge load and wear and cause these metal filings to come off, causing metallosis. So you have an elevated chromium and cobalt in your bloodstream, and it can cause some breakdown in the muscle tissue and cause pseudotumors and pain and so forth. I do revise those. I never put them in. That's an implant that even before it showed on the market, I never liked it, but it was successful in many ways. But it's no longer on the market. But if you are a patient that does have metal on metal and needs to be revised, we do revise that. I do revise those. The resurfacing is also a metal on metal implant, but its survival rate is very good because they heat treated the metal different. It's a different design. And so rarely do we have patients that need to have the resurfacings revised because of their success in the design and the material.
Very good. Thank you so much. Next question was, or is, I had a pulmonary embolism about 6 months after an ACL repair. Would this be a big risk for a total knee?
So very good question. Pulmonary emboli can happen, but it's less than 1%. What we do, because you are at increased risk when you have your hip or knee replaced, of having what we call a DVT, or a deep venous thrombosis in your leg that can pass up your leg into your lungs and cause a pulmonary embolus, which is bad. So what we do is we do many, many steps to help prevent the risk of that. One is by having a spinal. Studies have shown that when you have a spinal anesthesia, it lowers the risk of having a DVT. Also, because the surgery is short, you're not as sedentary, and I get you up walking the same day within hours, that lowers the risk of a DVT. When you're in the hospital and you stay overnight, we give you these foot pumps that squeeze your feet to prevent you from having a DVT. And we also give you aspirin or other anticoagulants, depending upon your risk factors. Some people come in with a risk of having DVTs. I'm going to put you on an anticoagulant that will help prevent that risk. If you're someone that doesn't have a risk factor, then we'll just do baby aspirin. So we take it very, very seriously. We have an excellent track record. It's very, very rare that we have a patient that ends up having a PE from a hip or knee replacement.
Great, thank you. Next question is the treatment for a torn meniscus the same as for osteoarthritis?
So if you have a torn meniscus, the meniscus is, I call it the gasket that sits in the knee joint between the femur and the tibia. And it acts like a little cushion, and sometimes you can tear it. So you probably had friends that were playing tennis or playing a sport or just twisting their knee and they go, oh my God, my knee hurts. That instant pain could be because you tore the meniscus and it flaps in the knee joint. So now you've got a little thing flapping in there and it's like walking on a pebble and it hurts. So that's usually treated with an arthroscopy, which is a scope where you go in and we trim it. And it's a 10-15 minute procedure with 2 little portal sites, and we do it under camera and we zip in and it's like trimming a hangnail. You just trim it back and then you get rid of the meniscus. So that's different from a knee replacement. Knee replacement is osteoarthritis. Now, if you have a tear of a meniscus and you've had it repaired or trimmed back over years, you lose that cushion, you end up having bone on bone, which can lead to osteoarthritis. And then that's when you reach the end stage osteoarthritis is when you need a joint replacement.
Great, thank you very much. Next question is, I'm 76 years old. I have severe osteoporosis of the hip. If I break the hip, will it be a difficult prognosis?
You know, osteoporosis or thinning of the bone does add some risk factors. That's why should you break your hip, hopefully you never do, we can fix it. We have all the tricks of the trade to do that. Again, you'll probably want to have a fellowship trained orthopedist who does hips to do the surgery, but it can be repaired. But let's hope that doesn't happen.
Very good, thank you. Next question is, how do you know when to have a knee replacement?
So as I tell everyone for hip and knees, if you reach a point where you've done all conservative measures, you have constant pain, you can't keep up with your friends and do the things you want to do, and you're chewing on pain pills or anti-inflammatories, and you can almost get depressed and you're limited, then it's really like, okay, uncle, we need to get something done. You've done all the conservative measures. That's when you say, okay, it's time to get your knee replaced.
Good. Thank you. Next question is, I'm suffering from the effects of COVID-19, like inflammation of the joints. How can this be treated if the pain and anti-inflammatories don't help?
So that's a little bit out of my bailiwick. I think a infectious disease doctor could answer that. I could tell you though that I have seen patients who are COVID-19 have joint pain, and usually it resolves with anti-inflammatories. The COVID-19 is not going to cause osteoarthritis. It's not going to lead to osteoarthritis. It's more of an inflammatory. You have multi-joint pain. And that's something that you may talk to your primary care or speak to a rheumatologist, and they can go through that with you.
Great. Thank you very much. Next question is, my spinal anesthesia did not work in the past. Is there another anesthesia option that would work just as good for a joint replacement?
So rarely do we have patients who come in and a spinal anesthesia does not work. It's a very small percentage. So then if that happens, then they end up having a general anesthesia, and then the surgery is performed. Usually though, with the techniques that we have now, we're able to do it. But there's only that option. It's either the regional or the general. There's nothing in between.
Great. Thank you very much. Next one, I'm going to combine a couple questions here. What's the recovery period for knee replacement so that one can re-engage in daily functions? And somebody else asked, how long does it take to heal after knee replacement? When can I drive? When can I hike?
Okay, so bottom line, what's the recovery? And here's kind of the timeline that I tell my patients for knee replacement. You come in, you have your surgery that same day. I get you up walking. The physical therapist is going to work with you. You either go home the same day or the next day. Maybe you'll stay 2 days if you really need it. But you're going to, when you leave, you'll be able to get in and out of bed on your own. You're going to be able to climb stairs and go downstairs. So you have some independence. So when you go home, you're not like sitting there having to have someone be on you hand and foot 24/7. You'll be able to get around, move around, get in and out of bed, walk to the kitchen, the bathroom, and so forth. Now, the first few weeks are going to be a little sore, so you have to elevate and ice and take your pain meds as needed. And you'll work with a therapist. Either they come to your house or you go to outpatient therapy. And so you'll be stiff and sore for a few weeks. If it's your right knee and you want to drive, I would say 3 weeks before you drive. If it's your left knee, you want to drive, I would say 2 weeks before you drive. Overall, though, the first 3 weeks, a little, I'll be candid, there it hurts and you'll be sore, but you'll be okay. It's not, and it's a new pain. It's not the same pain you had before. It's more surgical pain. It's healing pain. And every day and week gets better. By 2-3 weeks, by 6 weeks, you feel even better. You're more mobile. You're out and about, maybe using a cane or nothing. And then by 3 months, you really are feeling quite good. Some people 6 months to just really have the strength back and full range of motion. But most of my patients, 3 months, they're doing well, they're feeling independent, getting back to the things they want to do.
Great. Thank you very much. Next question is, do I need a referral from my primary care doctor to see you, or can I just make an appointment with you directly?
Well, that actually depends upon your insurance. First off, if you're Kaiser, you can't see me because I'm not a Kaiser doc. We're in a private practice. If you are an HMO, then you'll need a referral from your primary care. If you are a PPO, then you can just call the office and set up an appointment.
Great. Thank you. The next question is, and just a couple more, how do you determine if it will be a same-day knee replacement surgery or an overnight case?
A lot of it really entails your health history. If you're young, active, and you're doing great, very few medical problems, you probably can go home the same day. If you're, I'm not too sure, I want to spend a little extra time overnight, I want to make sure that my pain's controlled, maybe I'll spend the night with you guys in case you have to give me pain meds IV. then that reservation could spend the night and go the next morning. So those are kind of, we look at it differently. If you're 85, definitely will, in your 80s or late 70s, 80s, spend the night and then go home the next day, or spend 2 nights and go home.
Great. Thank you so much. The next question is, I had a total knee replacement in June 2021 by a different doctor. I was
Okay.
told it's a case-by-case basis, but usually 1 year is the full recovery. I still have Pantheon pain inside my knees. Is that normal?
On an independent question like that, could happen, but I would have to see your x-rays, do a clinical exam, and then be able to tell you one way or the other what the story is.
Great. And remember, you can put that information in the form and also just schedule a call or a consult with Dr. Callander as well. The next question is, for a replacement, should I be a certain weight? After surgery, are you supposed to start walking right away? And is walking pain-free?
Good question. So weight is a big deal. If your BMI is 35, your body mass index, the BMI, if it's 35 or higher, more often than not, we will not do the surgery, because literature and research has shown that you have a higher risk of failure from the standpoint of infection, poor outcome with rehab, mobility, and just your overall postoperative course. So I and my colleagues are pretty big sticklers on that. So let's say you have a very, very high BMI, it's best that you really work on weight loss, maybe talk to a GI doctor, getting a nutritionist. There are lots of different paths, and we have options for you at Novato, where we can set you up on weight loss program that's excellent, and I'm quite impressed. So can you get up and start walking? Absolutely. The more the better. Except I don't want you to just go home the day of surgery and decide and walk around the block 10 times, because that's going to inflame the joint, get swollen. So it's a stepwise increase on how much I want you to pick up walking, but you won't be pain-free right away, because hello, you just had surgery. But as you heal, the pain is going to go down and your mobility is going to go up.
Great. Next question is, I had a total hip replacement 14 years ago. The surgeon said he had to pull it, extend it so that the length was even. Recently, I've had more cramps on that leg. Could that be because of the pulling?
No, the cramping is not from that. And what I think the surgeon was saying is they pull it, and when he probably, to make you even, he pulled it out, put a head on, and the heads come on different sizes, +1, +3, +5. And we put those on to get your leg a certain length. So that's, I think, the interpretation I see with that question.
Great. Next question is, you mentioned recovery time for knees. What is the recovery time for hip replacement?
Good question. So for hips, a little shorter, but again, you'll go home. When you go home, the physical therapist will complete your confidence level of being able to, get in and out of bed on your own, be able to do stairs, and you'll be able to pick up the paces. And then 3 weeks, you feel pretty good, and 6 weeks, even better. Your mobility will increase a little quicker than a knee, because again, a knee hurts a little bit more and you're stiff, whereas a hip, you have more mobility. But again, with hips, at 3 months, I tell my patients they can pretty much get back to doing what they want to do. That one video that I showed you, that gentleman who had a hip resurfacing, he was 3 months out from surgery.
Very good. Well, thank you so much. The next question, and we're down to the last two.
Okay.
I'm in physical therapy for my osteoarthritis for my knee, but it's really difficult to strengthen the muscles because I'm in pain and I can't do all the exercise as much as I should. It seems to be a very slow process to build up the muscles around the knee. What are your thoughts on that, and any suggestions?
Well, that's a tricky one, because you can kind of get stuck between a rock and a hard place, because you're trying to move, you're trying to get your mobility, you're trying to get strong, but it hurts. So, doc, what do I do? Well, your orthopedist should consider maybe cortisone injection, maybe the visco supplementation hyaluronic injection might be an option while you're getting your mobility. Or maybe you've reached a point where it's so bad you should think about getting it fixed.
Very good. The last question I've got here is, what is the downside of removing meniscus if the knee has osteoarthritis?
So if the knee has osteoarthritis already, and the downside of taking out the meniscus, well, so for instance, if someone has osteoarthritis in their knee joint, they may already have pain. However, they may have a meniscus tear, which can cause some sharp pain. Okay, so you have some sharp pain where, oh boy, I twist and it just hurts a lot. But you can also have kind of a chronic dull pain, and that comes from the osteoarthritis, the wear of the joint. So sometimes if you take out a portion of that meniscus that's kind of flipped on itself, that's causing that sharp pain, that will give you some relief, but it's not going to give you the relief of the gradual generalized arthritic pain in the joint. So is there a downside of that? No, but your likelihood of having success from that procedure, you may have a few months of relief, maybe more, but you're back to square one really because you have osteoarthritis in the joint.
Great. Well, that was the last question. So if anybody thinks of a question between now and the very end, you can simply put it in the form. Remember, you are going to get a little feedback form that pops up at the end of the seminar. And we will, if you don't see the form tonight, don't worry, we're going to email it to everybody tomorrow as well. And with that, I will turn over to Dr. Callander to say a last few parting words.
Well, thank you, Sean, and thank you all for coming this evening. It hopefully didn't drag on too long, and I hope you learned a little bit about the latest and greatest in hip and knees. But I do want to say is that working at Novato Community Hospital has been a real dream for me, and why that is because the staff is absolutely terrific. They do a bang up job with their overall treatment of the patient. I find that the patients there are quite happy. They always are giving wonderful testimonials about their experience. And a lot of that is just because the staff really care. And I love that because when I come to work at Novato, everyone just really steps up to the plate to make it a win-win situation. So 3 cheers for Novato Community Hospital. I think it's a wonderful place to work, and it's a super place to come and get your hip and knee replacement. So thank you very much. Stay safe out there. And again, many thanks for joining us. Have a good evening.